Rush protocol, rapid ultrasound in shock and hypotension. The Rush protocol is a structured point of care ultrasound approach to quickly identify the cause of undifferentiated shock and guide resuscitation. In the Rush protocol, we evaluate the pump, tank, and pipes. The pump is the heart, and we evaluate the heart for contractility, LV function, pericardial effusion or tamponade, and right ventricular strain, indicative of pulmonary embolism or pulmonary hypertension. The tank. The central tank is the IVC, and we assess it for preload. The peripheral tank, we do a fast scan for fluid loss or internal bleeding. And the lung bases, we look for pleural effusions or B lines suggestive of volume overload. The pipes. We assess the aorta for aortic aneurysms or rupture, femoral and popliteal veins, looking for DVT if we are suspecting PE, and we look at the chest for pneumothorax or an obstructive pathology. The simplest way to approach the Rush protocol is by using the mnemonic HI map. H stands for heart, and here we assess the contractility of the left ventricle, the right ventricle size, and we look for pericardial effusions. I stands for IVC, and here we estimate the volume status. M stands for Morrison's pouch or the fast, and here we look for internal bleeding or free fluid. A stands for aorta, and here we check for any aneurysms or dissection. P stands for pneumothorax or pulmonary, and we look for tension pneumothorax or pulmonary edema. This table summarizes the components of HIMAP, the systems assessed, and where we place our probe or the window, and finally the findings or the interpretation of each of those views. So where do we assess the heart? We can use the subxiphoid, parasternal long axis, parasternal short axis, as well as the apical views. And here we look at the cardiac contractility of the left ventricle, particularly if you're suspecting cardiogenic shock. And if you see a significant pericardial effusion, that could lead to obstructive shock. To assess the IVC, you need to place the probe in longitudinal direction over the subxiphoid area. And here we look for the collapsibility or the non-collapsibility of the IVC. So if the IVC is flat or the collapsibility is more than 50%, then it could be hypovolemic or hemorrhagic shock. And if it's plethoric or non-collapsing, it could be obstructive or cardiogenic shock. And then we do the fast views. And here we are looking for free fluid suggestive of hypovolemia or hemorrhagic shock. The aorta, we need to place the probe in the epigastric area and then slide the probe caudally. We need to view the aorta in both longitudinal and transverse directions. And here we're looking for a AAA dissection, and the type of shock would be either obstructive or hypovolemic. And finally, the pulmonary assessment. And here we're looking at the anterior chest. We're looking for absent lung sliding, indicative of tension pneumothorax. And we also look for B lines, suggestive of cardiogenic or septic shock. So, how do we interpret our findings to arrive at a diagnosis? If you see a small left ventricle, a flat IVC, and no pericardial effusions, no B lines, then it's likely to be a hypovolemic shock. If you're seeing poor LV function, a plethoric IVC, and multiple B lines, then it's likely to be cardiogenic shock. If you're seeing a dilated right ventricle, or pericardial effusion, or absent lung sliding, then it's likely to be an obstructive shock. So, here, depending on your findings, it could be a pulmonary embolism, tamponade, or a tension pneumothorax. If you're seeing hyperdynamic left ventricle, a variable IVC with clear lungs, then it's likely to be distributive. For example, septic shock. You must, of course, remember that the rush protocol is merely a tool that you could use to diagnose as well as guide your management, and that it does not replace your clinical findings. So, you must always make sure that you relate your ultrasound findings with your clinical findings. The other pitfalls are over reliance on IVC size, which can also be affected by ventilation, missing subtle pericardial effusion, misidentifying pleural line artifacts. The key takeaway is that the RUSH protocol integrates cardiac, vascular, and thoracoabdominal assessment to guide immediate management at the bedside.